Good morning, everyone. I am Shantanu Das, and I'll be presenting a paper on cerebrospinal fluid leak, a rare complication of orbital exenteration. Orbital exenteration is a radical and disfiguring procedure which was first described by George Bartish in 1583. It is of three types. Total involves removal of all the contents of the orbit with or without removal of the eyelids. Subtotal orbital contents are removed partially with the removal of the ocular bulb. Extended when the adjoining bones and the paranasal sinuses are removed. CSF leak, although a rare complication, but it can be a life-threatening one as it can lead to meningitis, delayed cerebral abscess, seizures, CSF hypotension, headache, occult hemorrhage, and even death. Since orbital apex and the skull base is involved while doing exenteration, aggressive lesions, the risk of CSF leak increases because it usually produces a conduit between the paranasal sinuses and the intracranial space. In literature, the reported rate of CSF rhinorrhea is 1.6 to 16.7%. So the aim of this paper is to demonstrate our experience of managing two cases of CSF rhinorrhea during orbital exenteration and to highlight the management techniques of CSF rhinorrhea along with a review of literature. So this is the first case. A 86-year-old male patient presented to us with a left-sided lower eyelid swelling since 3 years. Diagnostic biopsy revealed sebaceous cell carcinoma. MRI orbits revealed extension into the mid-orbit with involvement of the medial and the inferior rectus muscle. So the plan was a left-sided upper eyelid lid sparing orbital exenteration. So during intraoperatively, a CSF leak was observed from the cut end of the optic nerve stump, and a fascia lata was harvested to cover up the defect. Post-operative outcome, he was advised complete bed rest. Intravenous antibiotics were given. There were no symptoms and the patient was discharged on the 4th post-operative day, but he returned to us 3 days after with headache and CSF rhinorrhea. At that time, he was treated with systemic antibiotics like ceftriaxone, amikacin, and metronidazole, complete bed rest with head and elevation. Acetazolamide tablet was given 3 times daily, IV fluids, lumbar puncture was normal, and after 1 week, the headache reduced and there was no CSF rhinorrhea. So the second case, a young diabetic alcoholic presented to us with left-sided mucormycosis. CT scan of the orbit shows hypodense area suggestive of either brain abscess or fungal granuloma in the bilateral frontal lobe. Outcome, during the left-sided orbital exenteration, CSF leak was observed from the damaged cribriform plate through the medial wall into the orbital cavity, and it was sealed with a periorbital galeal flap. Post-operatively, he was advised complete bed rest with head and elevation, and IV broad-spectrum antibiotics and antifungals were given. There were no more episodes of CSF leak. Management, CSF differs from blood when it is placed on filter paper. It produces a halo. Measuring glucose content is another method, but it is not reliable. Beta-2 transferrin is the most sensitive and the specific method, and majority of the leaks can be localized using a non-contrast high-resolution CT. So intraoperative treatment, regional flaps like pericranial and galeal flaps are very good and can be harvested easily. If there is adequate exposure, a primary suturing can be done. Many neurosurgeons prefer a onlay graft which can be easily harvested from a layer of fat or a temporalis muscle. Autologous grafts like fascia lata, osteomucoperiosteal flaps can be used. Mucous membrane, although can be used, is associated with infection, and lyophilized dura has the drawback of transmitting Prions disease. Again, intraoperative fascia lata is the treatment of choice as it is flexible and allows large defects to be closed. Since it has thin and low mass properties, large dural defects can be closed easily. Tissue adhesives like Tissel fibrin, cyanoacrylate glue can be used. Bone max has been used to seal small defects, but the problem is it prevents fibrin deposition and spontaneous healing and closure. Other risk is granuloma formation. Other materials that has been successfully used are gel foam, vicryl mesh, and hydroxyapatite cement. Even bioglue can be used, which has been seen to persist at the surgical site for even 2 years post-op. Post-operatively, complete bed rest with head and elevation at 15 to 30 degrees. The patient should avoid sneezing, coughing, and straining and should be given stool softeners. Prophylactic broad-spectrum antibiotics should be started. They prevent meningitis. If it doesn't subside, then we can place a spinal catheter and drain CSF at the rate of 5 to 10 ml per hour. Excessive drainage should be avoided as it can lead to tension pneumothorax. Acetazolamide has been shown to reduce CSF production and is frequently used to treat such conditions, but you will have to monitor electrolytes as it can lead to hypokalemia and regular ECG is needed. If all these measures fail, then only we go for a surgical intervention, endonasal endoscopic repair, and if the leak is large and it is inaccessible, then we can do a craniotomy and repair. So in conclusion, CSF rhinorrhea during orbital exenteration is rare, but it's a life-threatening condition. A multidisciplinary approach is often needed to treat such conditions. Prompt and immediate sealing during the intraoperative and postoperative intervention is important to prevent deadly complications.